Well, hello, and welcome to another session of Surgical Pathology, Digital Slide Review and Sign Out. I'm Dr. Lewis Hossel, and we're a project taken in conjunction with the Digital Anatomic Pathology Academy, which is a joint venture of the Digital Pathology Association and Path Presenter. My time is spent mostly here on the campus of the University of Oklahoma Health Sciences Center, and from time to time in our NIH-designated Stevenson Cancer Center, seen here. So our cases today, drawn mostly from our surgical pathology files, and our incident case is a 45-year-old woman who has experienced some abnormal uterine bleeding. She is slightly obese and has a history of unopposed estrogen from time to time due to polycyclic ovary disease. Her biopsy showed an endometrial adenocarcinoma, and so she came to hysterectomy because her child-rearing days were completed. And here we see a nice picture of her full-thickness endometrial cavity or endometrial surface, myometrium, and on out to the serosa. As we see on the left, this tumor is fairly solid-looking, low magnification, although we can see a sieve-like pattern, and it's occupying the entire surface of the endometrium and extending into the myometrium in several areas, as we see here. Now, in addition, we note that there's some deep structured areas that are also occupied by this a proliferation, slightly different with a little more blue associated with it. So let's take a look at her neoplasm, and we can see that this tumor occupying and forming a mass in her endometrial cavity is composed of glandular tissue with mostly open glands, a few closed smaller ones, but mostly open, and lined by columnar epithelium with generally ovoid nuclei, somewhat vesicular appearing, and at high magnification, not too much in the way of macronucleoli. So these are still fairly low-grade nuclei. The glands appear fairly low-grade without areas of solid tissue, save for perhaps right here we see an area where we have solid tissue in the lumen of this gland here. And this represents squamous metaplasia or squamous differentiation in the tumor, which begins to form solid type tissue. We can see, however, that also there is some cribriform type formation with this glandular tissue. And here's more areas of this squamous sort of differentiation as we look around. Now, as we go into this tumor a little bit more fully and sort of look to see what's going on down in the myometrium, we'll take this as one of the more deeply penetrating areas and examine that. One of the things we see here is that we see two different types of glands here. So notice first here that we have this gland here, which is a benign endometrial type gland, very compact glandular tissue, uniform cells, not much pleomorphism, no vesiculation to the nuclei. In contrast, these glands here next door are quite distinct. They have sort of a vacuolar or vesicular change to the nucleus. The cells are much larger. There's a little bit more disarray, and these look like the glands that we had up on the surface. In addition, we see the squamous metaplasia here, and we see some intraluminal desquamative cells or debris that's forming here as well. Well, what's to explain this? Well, the other feature that we see here is we see a blue stroma admixed with these glandular tissues that says this is adenomyosis. So this bluer tissue is adenomyosis, and it appears, because we have a little bit of that blue tissue surrounding this invaginating tufts of tissue, that this is actually adenocarcinoma that is extending down adenomyosis partway through the myometrium. Now, as we can see, this adenomyosis is present elsewhere and extends well into the myometrium, nearly to the serosa, as we can see here. Here are benign endometrial type glands surrounded by stroma, right here out to the level of the exterior surface. Now, there's another area we had highlighted up here, which also bears looking at, and that is this particular area here. Are these deeply invasive tumor cells? As we see, we've got the squamous metaplasia here again. We've got the large cells with vesicular nuclei, very scant stroma, and a little bit of peripheral tissue that looks like it might be stroma. But again, looking here, we can see that we have these very bland endometrial type glands amidst the stroma that are indicative of adenomyosis. So in fact, these are still essentially in situ endometrial adenocarcinomatous glands that extend very deeply into adenomyosis, nearly to the serosa in this patient. But in fact, we have no single cells, we have no desmoplastic reaction to this tumor, and in every instance where we look, we can see a band of endometrial type stroma surrounding these glands if there are no glands there. So this is all indicative of endometrial adenocarcinoma with squamous metaplasia that is still essentially in situ because it is extended down adenomyosis, partially involving it. Now, if this were only a small amount of adenomyosis, this would be much harder, and we would have to be very alert for these rare glands. But since we have such pronounced adenomyosis elsewhere, it's easier to detect. So this case illustrates some of the challenges with properly grading and staging endometrial adenocarcinomas. There are several other challenges that come up as well. First of all is correctly identifying any subtypes or other types of carcinoma that have a different prognosis. Dedifferentiated carcinoma we've talked about in another video, which we'll reference at the end. Sarcomatous carcinomas we've also talked about, and clear cell and serous are important tumors as well. A second challenge is correctly establishing the grade. And then, as we've just illustrated, correctly determining the depth of invasion and measuring that to determine whether it's a stage 1A or a stage 1B. And then finally, we want to identify other risk factors that place patients into a high or intermediate category of risk that may require further adjuvant or further staging evaluation at the time, such as lymphovascular space invasion, stromal invasion involving the lower uterine segment or cervix or any of the adnexae, and of course, serosal involvement. So just as a matter of review, let's take a look at this serous carcinoma. Now this can look in many instances like endometrial adenocarcinoma of the usual type. It can have nice glandular formations and some solid areas and so forth. The things that should tip us off to make us be concerned are the presence of high-grade nuclei, such as you see here, and the presence of micropapillary structures such as this. These are hallmarks that would say, I'm not usual endometrioid carcinoma, think about serous. And then, of course, once you've had that thought, you'll probably want to do a p53 immunoperoxidase stain or some other mechanism to establish mutation status that will help you to reliably make that diagnosis. Now, as we've just saw with our incident case, these tumors can have squamous differentiation. And a frequent pitfall for people is to mistake clear cell carcinomas that have these very clear cytoplasm and sharp nuclear borders with tumors that are showing squamous metaplasia. And so if we were to look at a very high power field of some of this area, we might be mistaken in thinking, oh, this is just squamous differentiation in an otherwise glandular tumor, and mistake it as endometrioid carcinoma with squamous differentiation rather than clear cell carcinoma. Again, the feature that can help you is the high-grade nuclear features, and of course, if you're fortunate enough to find them, things like hobnail cells and so forth that are more characteristic of clear cell carcinomas. So let's look next then at the grading issue. And one of the features that is a pitfall is mistaking poor fixation for solid pattern growth. This is, I believe, one of the instances where pathologists can potentially induce patient harm is if they are not very attentive to their procedures pre-analytically to make sure that tumors get fixed thoroughly and promptly so that they can be properly classified. It's all too frequent that over the course of my career, I've seen cases where the uterus was removed and dumped into formalin overnight or for over a weekend, and when it arrived in the laboratory, the endometrial cavity was virtually and totally autolyzed. And as you can see here, some of these glands are very difficult to distinguish from benign glands or neoplastic glands. Is it solid growth or is it discohesive glandular tissue? In many of these circumstances, you feel fortunate to be able to establish the diagnosis of cancer, let alone to be able to accurately grade it and stage the tumor for best therapeutic options. So make sure your procedures allow for correct fixation. Now, this is a tumor which is forming glandular spaces. It has a complex appearance. It's not just a proliferative endometrium. It's got some areas of solid growth where the tumor cells are more solid, like here, and so forth. And so grading requires that we provide some sort of an estimate and a determination as to how much of that solid type growth is present. But generally, when most of the glands are wide open of this sort, there's not going to be much solid growth. But as the tumor becomes more proliferative, the amount of open clear space in the lesion declines, and then it begins to cross over the threshold to grade 2. Now, another factor is to, again, define invasion. And adenomyosis, as we've talked about, is one of those things that can be very difficult to distinguish involvement by tumor or just benign adenomyosis. Here, I think we can see there's plenty of space here between the glands. This is adenomyosis. Whereas up here in the endometrium, we have more closely spaced glands, smaller glands. Again, they're mostly open, but they begin to become a little bit more closed and compacted together. And the epithelium begins to be heaped up a little bit. So this is the beginnings of solid growth. Areas like this show the beginnings of solid growth. Areas like this, while having an open glandular space, that shows multiple layers of cells that begins to be of a more solid type. And so this begins to form, a 1 or 2% of solid type growth. So let's talk about grading in more specifics here. The cut points of importance are 5% and 50%. So this is a wide gap that is filled by grade 2. If it's more than 5%, it's grade 2 endometrioid carcinoma. If it's more than 50%, then we move it into the grade 3 category. Now, this may seem to be a fairly wide gap, and most people can get it, but in actuality, the reproducibility has been less than stellar. We don't use morphometry. We don't use analytic image analysis because these criteria were developed before that era, back in the 70s. and perhaps even before. Now, it's also true that we should look at the nuclear grade. And anytime we see high-grade nuclei that don't fit with a grade 1 or 2, then we can move it up based on the nuclear grade to a higher grade. Because of the reproducibility problem, there are several non-FIGO grading systems that include factors like necrosis, infiltrative pattern, even mitotic index. But these are not widely applied. And while they have some advantages in terms of reproducibility, until they're more generally accepted and endorsed by some of the larger organizations, I think we're going to be using a 3-tier grading system. Now, many of these newer systems have a 2-tier grading system, which inherently would be more reproducible, of course. So let's look at a couple of examples and try to apply these standards for grading. So here's a tumor at low magnification. We can see that it appears to be invasive of the myometrium, and there's a lot of blue in this tumor. It's got a little bit of open spacing here. We can see some formed glands. And so we can begin to look at this and evaluate this. And this is one of these tumors that is difficult for many people to classify, because when they come to high magnification, they may look and say, well, there's a gland, here's a gland, here's a gland. This is all glandular tissue. There's not solid growth. But in reality, this is solid growth here. Another area we could look at that would be solid growth would be, this area here would be solid growth. We could look at another area over here where we see more solid growth, where this is becoming more solid growth here. And we begin to cross that threshold from grade 1 to grade 2 when you start to see this much solid growth in a single high power field. Now, we'd want to look to see, do we have other areas where we have more sheets of tumor, in which case it might even move to grade 3 based on that. But it looks as though most of it is this small glandular cribriform and more solid compact glandular growth. Now, I said let's look at the nuclei. We should look at the nuclei and see, do these nuclei reach grade 3 in terms of our characteristics? Well, what constitutes a grade 3 nucleus? We can think of serous carcinomas, we can think of clear cell carcinomas, since those are by definition grade 3. But usually there is a prominent nucleolus, and we can see a few cells with a very prominent nucleolus. There's a thickened nuclear membrane, probably irregular, and there's a degree of nuclear hyperchromasia. And these nuclei, they fit for grade 2, but they don't make it to grade 3. There is an increased mitotic rate here. We do see mitotic figures and so forth. But we don't see very many nuclei, even maybe this one's here a little bit on the larger side, might make it almost to grade 3, but the overall grading, another one here, it's a higher grade type of nucleus that we would want to pay attention to, but overall we don't quite make it, I think, to a grade 3 nucleus. So this would be a nice example of a grade 2 endometrioid adenocarcinoma that is invading the myometrium. Now, what does one do if you have, say, grade 3 tumor up near the surface and mostly solid growth in an area like this versus maybe your infiltrative component is composed of more glandular tissue like this? And there's no criteria for making the distinction in that situation. There's no grading of different portions or percentage grading that is allowed. You're to take the overall appearance and grade on that basis. Now, pattern is important, and this tumor gives us another issue of some challenge sometimes. It again appears like we're very superficially invasive. This is a tumor that's composed of large glandular structures with a very prominent intraluminal micropapillary appearance. So this is a common conundrum. Do we see this as then micropapillary serous carcinoma? Do we consider that as the concern here? Well, again, this is where nuclear grading is helpful to you. because these nuclei are not grade 3 nuclei. Uterine papillary serous carcinoma has a papillary architecture or a small glandular architecture, but it also has high-grade nuclei. So what do we do when we have a disconnect? What I do typically is to look at the mutation status by testing with a p53 immunoperoxidase stain to reassure myself that these are still non-mutated micropapillary structures, but not papillary serous carcinoma. And so when you have that disconnect of architecture and nuclear grade, that is always a good idea. And in some institutions, it's fairly routine to do p53 testing on most, if not all, of their endometrial carcinomas to make sure that they aren't missing a mutation status for a potentially higher grade tumor. In a tumor like this, we would expect there to be, a wild type pattern where you have heterogeneous p53 staining in the nuclei rather than either uniformly strongly expressed or uniformly absent, the so-called null phenotype. So the next challenge that we want to bring up in this discussion is the issue of measuring the depth of invasion. This is one of the diagrams that's taken from the CAP cancer checklist. The notes at the back of these protocols are very useful and should be reviewed from time to time, particularly as early in training. So here we see the issues in terms of measuring depth of invasion. These jagged nests are the invasive tumor. The undulating line is the boundary between myometrium and tumor in the endometrium. And as you can see, where it's a fairly uniform superficial line, we measure from that deepest point to the deepest point of invasion. That's straightforward. Where it's a more undulating line, again, we measure from the deepest point of the endomyometrial junction to the point of clear-cut invasion. Where things get a little bit more dicey is where we have an exophytic tumor that is clearly penetrating the myometrium, and we try to approximate where the endomyometrial junction is and extrapolate and measure from that point. So with this type of a tumor, some people's extrapolation may be here, somebody else's extrapolation may be here, and you can see that that can make a significant difference. We certainly don't want to measure from anywhere up here on the surface. We do want to try to do that. The challenge here, of course, is what happens if my section is cut off here and cut off here? What do I use as my extrapolation? You're using a suboptimal section to measure the depth of invasion, and so your staging may be inaccurate. And that creates a problem and should guide one as they take sections to try to include sections where you have less exophytic tumor growth, the boundaries of that, as well as the central portions where you're likely to have deepest invasion, so that you can make that extrapolation a little bit more accurately. Now, if you have this undulating or exophytic papillary polypoid lesion, such as in diagram D here, and an invasive focus, you again measure from the extrapolated endomyometrial junction to the deepest point of invasion. And finally, as we saw in our first case, when we have a situation of adenomyosis, which is involved by tumor, we measure anything that we've defined as clearly invasive from that deepest point of adenomyosis involvement to the deepest point of invasive tumor. This is an even more difficult and subjective application of the grading criteria, one of the more challenging ones. And it's also the reason why when we provide depth of invasion in the cancer protocol, we also provide information about presence or absence of adenomyosis and whether or not it is involved by carcinoma. So let's just look at a couple of other examples to illustrate some of the problems with tumor, measuring depth of invasion. And the first one is, as I've indicated, getting a good section is very, very important. So here is a section of endometrial carcinoma and a surrounding myometrium. Here we'll go to high magnification. You can see that this is tumor, again, with areas of squamous differentiation, which, as I should have mentioned earlier, of course, does not apply when calculating the proportion of solid tumor growth. That can be difficult at times. But anyway, we've got endometrial adenocarcinoma, we've got some surrounding stroma, and we also have areas where we have an irregular interface, probably some invasion, but it could still be adenomyosis because we have some areas where we have benign glands here. Now, in addition, we also see that we have serosa out here, but we don't see the endometrial surface. We don't know where this is relative to the endometrium. Are we out in the cornu? Are we in the fundus? We cannot use this section to obtain an accurate depth of invasion, even whether it's adenomyosis or other type of involvement. And so it's important to get a nice transmural full thickness section that will illustrate the depth of invasion accurately and allow you to correctly stage it. Now, sometimes the myometrium is thicker than can fit into one block, in which case you can divide that section and use it in 2 or 3 blocks if needed, providing appropriate inking to orient the final sections. Here's another example, again, illustrating the problem that I mentioned in the diagrams. Here we see that we have a very undulating endomyometrial junction. It goes down here. We've got maybe invasive tumor and so forth. We go along here, and we can see this sort of undulating appearance. The problem is that we cannot determine up above where the normal endomyometrial junction would be. And as we magnify here, is it here or is it up here, even higher? So because we don't have any normal endomyometrial junction, we have a very difficult time knowing how to measure from this slide. Now we can approximate whether or not we're into the outer half in these circumstances, because that is the cutoff for grading 1A versus 1B. And sometimes the vascular plexus here can help you in making that staging determination, because the vascular plexus in the mid-myometrium is usually at least halfway through the myometrium. But here we're sort of right on the border. And so this is a case where you're kind of trying to measure a depth of invasion without knowing where you measure from. And that sets you up for all sorts of subjectivity in terms of evaluating where to measure. So again, a difficult challenge with measuring, determining where to start from. You certainly don't start from the surface, but where, anywhere between there and down here do you measure from is unknown and difficult to define in this section. If you have to go back and get more sections, you should do that. Now, when you have tumor in a polyp, again, you don't measure from the top of the polyp, you measure from the tumor into the myometrium. Here is a case where, again, we have adenomyosis here that's not involved by tumor. And then we see, even here deep to the tumor, we've got some benign glands, whereas up here in this polypoid tumor, we've got a nice grade 1 to maybe grade 2, because we're starting to see some solid growth here of the tumor in this case. Let's look at one more example before we conclude this. And here's another situation. Here we can see we have a leiomyoma. And we don't measure the thickness of the myometrium from the surface through the leiomyoma to the serosa. So you do not do a measurement that goes from here down to here in your measurement. You want to measure an area of myometrium that is not as non-distorted by these other tumoral lesions in providing the depth, either in terms of total thickness or in terms of the invasion. So avoid areas where you have leiomyomata. Now here we can see that this would be our approximation of where the endometrial myometrial junction was, and we would probably measure, down to here. But because this has slightly distorted the myometrium, we don't know if this is really the serosal surface we should measure to. Based on the vasculature, again, we would estimate that we're probably within the inner half on this tumor. Let's just take a quick look at this tumor and decide, are we looking at a grade 1 or a grade 2 tumor? Again, we have a lot of open space. Looking at our nuclei, they're mostly vesicular, a little bit more coarse in some areas and a few macronucleoli, but nothing worse than that. We do see we have some squamous differentiation here in this tumor as well. And so this is a nice example of a grade 1 endometrioid adenocarcinoma with just a little bit of squamous differentiation, all open glandular type tissue, all the way down here to the more deeply invasive component of the tumor, where we're seeing some more of this squamous differentiation, which we again would not classify as part of the solid growth. So we've talked about some of those features in terms of the logistics of measuring and grading. What else are we concerned about with endometrial carcinoma? Well, in our institution, and I think for most places, determining whether or not the patient is microsatellite unstable, whether they have a mismatch repair defect is important, because that's going to govern some of the treatments available to them, and also may impact other risks of malignancy if they are a Lynch carrier with germline microsatellite instability. Looking at to see whether or not they have a p53 mutation or some of these other mutations like the DNA polymerase epsilon or a p10 mutation, those can also govern treatment and prognosis. In some circumstances, there are specific markers available to them. So providing some sort of a molecular characterization is also an important part of evaluating endometrial carcinomas. So our final diagnosis for today's case is endometrial adenocarcinoma of the endometrium with squamous differentiation. We graded it as a FIGO grade 1 involving adenomyosis, but without evidence of true invasion of the myometrium, even though it was very deeply present within the myometrium in the adenomyosis. Well, thank you for joining us today. If you like this, please subscribe and add some comments below. Also, if you look in the comments below, we've got a link to the digital slide presentation that you can look at your leisure. Please do subscribe so that you're able to catch up on future posting of these in this series. We'll look forward to seeing you again, and thanks for your attention.